The airway is muscle. And the minute you understand that, you understand almost everything else that we do and why it works and why it doesn't work. You can explain all surgery and the good outcomes and the bad outcomes by explaining muscle. You're not going to get it explaining the size of the jaw.
Well, hello guys, and welcome back to another episode of Mind Your Mouth. I am your host, Melissa Mugnino, and I am really excited today, very humbled and very honored to have the esteemed Dr. Stanley Liu join us on Mind Your Mouth. It's interesting, everybody I've had on the podcast so far, I do have like a very deep personal relationship with, I've hung out with, so I'm actually very, very a little nervous today to have you on, Dr. Stanley, because you are someone I look up to and admire and just am truly humbled by all of your work. So thank you for joining us today.
I'm humbled. We haven't had a chance to chill in one of our meetings. At the same time, though, I'm really impressed with the platform that you have built. And so I'm always eager to connect with the airway community and anything that we can gain momentum out of it. I'm all for it. So thanks for having me here.
Wow, it's truly a privilege. And I got to spend the last couple nights, doing my due diligence and research of just watching everything you've been on lately. And we obviously are both very close with Dr. Zaghi, and he, I just had him on last week as I was sharing with you. And we were just chatting about, you both with Dr. Christian Guilleminaud and you guys, the Stanford and all of those things. And it's just this beautiful reminder of how far we've come. I think a lot of times people talk about how far we need to go, but I was just this opportunity to reminisce about how much work has gone into where we are today. Mm-hmm. I rewatched an episode, and I'm going to let you introduce yourself because your credentials are impressive, extensive, and really lovely. But I wanted to talk about one thing I heard you say was you were talking about Dr. Christian Guilleminaud, and you had said most of this work that he had, you were in his office and it was from the 70s. Mm-hmm. And you were like, let's not wait another 40 years or 30 years to make this relevant and, in what we practice today. And I was just so humbled by that. I took a moment and I was like, wow, what a mind he had. And God, way to be someone I can't even imagine, all the things I went down with him. So if you would let the audience, for maybe the people that don't know who you are, just give us a little insight of who you are, what you do, and, why I have you on today.
Yeah. So I'm trained as a dentist, as a physician, as an oral maxillofacial surgeon, and ENT sleep surgeon. And I have then been teaching and working in the upper airway and the sleep space for the last, I guess, decade or more. So it does sound like an odd sequence of training. I'll just say that the pioneers of the field and my own mentors, the folks who, worked on the surgical protocols with Christian Guilleminaud, with CG, they were trained the same way. So in some ways, it was when I discovered this as a career and a calling, I knew that this combination of training is uniquely well positioned in the airway space. And we'll talk more about it, and hopefully it all makes sense. But this combination, it is a bit of a wasted childhood, but there is meaning there is purpose to this combined training and experience. And I've been very, very grateful.
Being in the space, I think your being able to have that perspective from those different views. And I think from an airway perspective, everything is three-dimensional, right? Structure, function, behavior. And I was like, of course he has a three-dimensional observation of the entire system and how we all evolve. So I just was so blown away by all of that. And then the other thing is you also teach at Stanford, but you practice in Florida. Am I correct? Am I wrong for that?
No. I had moved down here 2 years ago, coast to coast. Just traded palm trees in Palo Alto for the palm trees in South Florida. Apparently, they're different species, just so you know.
I actually, South Florida is like very home to me. My husband is actually the light scalpel rep for Florida and Louisiana. Yeah.
Okay.
And we have a place in Deerfield. So like South Florida is my mom lived down there for years. So I love it down there.
The water is warmer down here.
Yes, it
I would
is.
say that.
Absolutely.
Yeah.
The South is great. It's a fun place to be.
Just as many sleepy people, though, unfortunately.
So with that being said, are you practicing in Florida? So like if, we could send patients your way to come see you, right? And
so one of the cool things when I came down here was, so here in Nova Southeastern University, one of the cool things was the extreme proximity of the med school, the dental school. We have a speech therapy program. We have, anything from that to ultrasonography, nursing, pharmacy. So the idea is to put together a truly multi-dimensional practice. And so it's been slow in the build, but we have it. It's the NSU Sleep and Breathe Wellness Center. And this time around, it really does have all the components. So just as a quick comparison, Stanford was really great with the exception of not having anything dental. All right. In terms, there's no dental school, there's no dental representation. I mean, my first dentist that brought into my clinic was Audrey Yoon, right? I mean, that's how old all of us are, right? I mean, that literally was the first. And, if Sarush didn't go into, tongue tie and myofunctional therapy, I'm not so sure who would, right? But he took off from there. So, yes, a lot of this really did happen in the last decade. But we're honestly, as a field, we're still in search of that perfect one-stop shop for patients. So these days, I'm also in the business of going around the planet and trying to help people set up, these types of delivery systems, right? And I will say,
I was just joking. So as we were just starting,
I know, right?
Oh, that's a perfect segue because it's a big part of the only way to grow this industry is to set up really great businesses.
And I'll tell you the most recent one that I helped set up, I think really works very well. It's actually a full scope dental practice in Kuala Lumpur in Malaysia.
Okay.
And they built a sleep lab. And so I flew in and this is what we did. We had the patient come in, spent overnight, slept in the sleep lab, wakes up with all the, the EEGs and wires and everything on. I took him next door, same clinic, same practice. We did a sleep endoscopy with PSG on. We even took his CPAP, and this is based on our old research. I poked a hole in the mask, and we actually turned on the CPAP to look at the airway changes. We used his oral appliance to look at things as well. And then the dude wakes up, and then, probably gets some breakfast, gets his cone beam CTs and intraorals done, an exam done. And in less than 12 hours, he got something that will require 3 different specialties, 3 different doctors, and probably 2 years to do in the U.S. and anywhere else. So, but if you think about it though, right, the bar is not that high. I mean, okay, so you have a full scope dental practice with a sedation room and they build a sleep lab and that's it. So I just feel like all of us are just one tiny step away from achieving that. But as you know, it is difficult, whether it's regulations or whether it's, resources, it doesn't happen. But I think we're really close. I mean, we really need a few of these places where in 12 hours, we have all the information we need. The guy can go home and we can try to figure this out, right?
I'm a very much of a person that I believe I've learned over the years that you have to have patience. I'm definitely a person, I think most of us all have a story of why we're here and what brought us here. I tell a lot of people, I remember the exact moment when I sat in my first airway course. It was 2008 at Barry Rayfield's office. I'm originally from New Jersey. And I'm a hygienist, but I've always had a love for entrepreneurial businesses. I've owned multiple different ones. I love startups and taking people's passion and making them something that they can give back to the world and make it scalable and repeatable. It kind of like finding that why. And I sat in this course this time, and I remember like watching somebody put up a child that was late to school and struggling with behavioral issues, clenching their teeth, chewing on things. And I started to like tear up. And a buddy of mine who his dad's a neonatologist up in New Jersey. And he's the first dentist that we kind of like we tried to build something. And I looked at him and he goes, "Why are you crying?" And I said, "I feel like they're talking about me. For a long time, I just thought I was kind of a bad kid that didn't like to go to sleep, and I chewed on things because I didn't know. I just thought it was because I was broken, to be honest." And we went back and we worked for 3 years trying to create an airway practice where his, dad would send moms that had preemies and his wife was a pedo, and we would try to make this work. And, he came to me very humbly and he said, "Melissa," this was 2012. He goes, "I just don't think it's going to make money. And it's so much harder than we have the bandwidth." And Dr. Liu, like, "Stanley, that's why I left." I looked at him, I said, "I don't think I can go back and do dentistry the way we did it before." And that's what set me on my mission to start trying to help doctors create teams and figure out how to educate, because I saw the strains that it put on the patients, on the staff, on the providers, to be able to meet these people and send them across the country and all these different places. It's been like a mission to try to make this a little bit more accessible and easier because, it sounds like you obviously saw that as well. Like, you guys can look at it from a science aspect and figure out how to fix it, but how to implement it and deliver it is a whole other, obstacle on its own. So it's exciting to hear that I feel like everything happens perfectly to hear that that's something you're focusing on.
Yeah, you brought up so many great points. I have to jot a couple of these down because I don't want to miss it. One of the things you brought up too is once you see the value of breathing, airway, and the stuff that we recognize, as you say, it's hard to go back, right, to whatever form of practice that is. And it's so interesting because it's a common thread, right, across many of us, many of our colleagues. And that's why the airway space, I feel like, has a disproportionate number of very, very passionate providers where they often feel like they're on a true mission. One of the reasons why I really got excited and, it's impossible to leave this field is when you go to meetings, right, you do have a lot of cool people who, think, well, we talk about innovation, but it's also sad because what we're talking about is hardly innovative. I mean, breathing during sleep is really kind of important. There's nothing innovative about that, as a concept in itself, even though oftentimes we're seen as the slightly more innovative, forward-thinking clinicians. But the passion of our colleagues, undeniable, a big one. And the scaling or making it accessible. I always joke about it. I just realized, because when I was at Stanford, the way to do cool things was to do something really cool with the resources we had. And I always, in retrospect, I always felt like it was very impactful, but it was also maximally expensive. And it was maximally inaccessible. I mean, when we, for example, in the earlier days of doing our maxillary expansion procedures and, we started doing them with, endoscopic approaches and, all this guided and, the cool stuff that you could publish. And yeah, I mean, if you count the OR fees and you count, the 3D printing and then the fact that you need the, endoscopy for it, how expensive are we talking about? Yeah. Something that a lot of people need, right? And in these days, I'm going for the minimally expensive, maximally impactful. And again, just going back to that example, we did this research where we're like, okay, people say CPAP is effective. Okay, but what does it look like? Is it like the airway is just like a pipe? Like it's just dead stable like that? Well, no, I mean, no one's seen it. So my first fellow, Carlos Torre, he came up with this idea of, just kind of fudging with the mask. And so we were doing sleep endoscopy with a CPAP mask on. So we could see, it's distension of the lateral pharyngeal wall, doesn't really do much to the tongue. Okay, that's what gold standard looks like. Okay, I mean, we had to know. No one really saw it, right? So all these years, I mean, we published that in 2015, 16.
So Dr. Carlos
didn't make use of that.
I actually, when Carlos first left Miami, I actually spent a year with him I spent 6 months in his practice helping him build up the sinus and sleep. Yeah.
Okay. And I don't even think he's still doing that. But
no,
but then I am.
But his perfect example, he said to me, I mean, and I love him. I mean, what a brilliant mind.
Yeah.
And he said to me, when you brought it up.
Yeah.
He goes, Oh God, Melissa, because he's so like methodical and he
Yeah.
goes, this is not easy to like put into practice, you know? And
Right.
we would go back and forth and he
Yeah.
would tell me funny stories about Zaruch and he would
Yeah.
say, you know, like with them in class
Well, they were
together.
back to
So
back, right? He was
yeah,
first, Aruch was
yeah, one was
second,
ahead.
and I was the young faculty. So back then, they didn't feel much like fellows; they were just pretty much colleagues. So we're all same age,
What a cool group.
equally immature, and full of enthusiasm. Well, we still are. But point being, it's actually not difficult because what I do is I just ask the patient to bring in an extra mask, and you know what I do? I take the dental drill. First time I picked up a dental drill since I graduated from dental school. I drill a hole into the CPAP mask and then I float the scope through it. And I'm doing it routinely in clinic. When I do a sleep endoscopy today, it would be very little value for me to just do a sleep endoscopy. I want to do it using whatever the patient is using, whether it's an oral appliance, CPAP. Even if they're not using anything, I'm going to float a CPAP down just to see what that airway looks like when being treated by a reversible type agent. But the point I'm trying to make is we can make this expensive project, and Carlos wrote all this IRB and research, and we had this specialized mask. But it doesn't benefit everyday practice. But guess what? You know what? Just poke a hole in the thing and we can make it work. So
you can
I've been translating a lot of this kind of.
And tell me what I'm hearing from you
Yeah.
is that naturally, I feel like sometimes we actually overcomplicate things just because we're trying to figure it out. And another one, I know a colleague of your, Dr. Won Moon, I got invited one time and sat with him and went to this dinner. And he said to me, he goes, listen, this was a while ago. He goes, Melissa, he goes, first, like you have to treat that, 1% to 2%, like the people that are going to pay top, you have to use them as an opportunity to figure out what works and what doesn't. And he made a joke. He goes, you see that pocketbook you have? And I was very broke at the time. And he goes, it's, he goes, you bought that at like a knockoff. And I remember thinking like, maybe. And he goes, but here's why. He goes, because a really high-end designer had to design something to find out if it made sense. So then they could replicate it so that everybody could have it. He goes, I'm not saying that to offend anyone. He goes, but now you get to be able to carry that, have the same experience as somebody else. And it's lingered with me for so long. And I feel like we are in that time now, and having you do that, we can simplify things and make this way more accessible.
Yeah. So, it's about translation, and there is a lot there. And so it also makes me think that oftentimes there's a lot of stuff in the ivory tower. And then I think these days, with other mechanisms of communication, such as a podcast or whatnot, it'll start to draw people out of their shells, and kind of think about, is what I'm doing, does it need a little bit of data, need a little bit of proving, need a little bit of fine tuning and phenotyping? The answer is yes. But who says that research lives only in a university? Today, one of the things I'm building is a network of data, let's say, that will allow us to have real world data to answer the questions. Bottom line is this: you still need to collect data, and you still have to do your clinical research on that the way you would properly and communicate that. But who says that you only have universities doing that?
So
right?
Saying that we can have we could have different offices, different groups of people
Correct.
Collecting data. So that
your data is just as good, right? I mean, at this point in our field, we still have to answer to a lot of people, including patients and other colleagues, on the data of the stuff that we're doing. So we just have to collect them. Now, we have to collect them in a way that the data is usable. But once that's done, it's very powerful, the communication that we can have to our pediatricians, to our sleep medicine colleagues. But we just have to do it. So I don't know. I just feel like since I've had to transition between two quite different worlds, that it's been great. A lot of creativity happens when you're at two extremes, and then you're like, all right, well, clearly some things can still connect. And when they do, it's very powerful. It changes the way we think about nasal surgery, changes the way we think about maxillary expansion, and you realize that it is scalable. So, yeah.
And that's really exciting because, there's all those old little sayings that, and I guess a lot of the colleagues and people I've worked with will go to these rooms, we go to these courses, we take these courses, and it's really impactful knowledge. You get so inspired, you drink the Kool-Aid,
Mm-hmm.
and then you go back to your practice, and then it's like you almost become paralysis. Sometimes I've been in offices where team members can't even fathom understanding what the leader is telling them to do. And because they want to be perfect, they want to make sure they're doing right by their patients, and they want a repeatable outcome. And that is, it's tricky. So to take somebody like yourself who's been doing it on this higher level in that universal setting and doing the research and all that, and now actually really working and implementing it, that's really powerful. And I'm absolutely loving all of that, because it's really important work to really make it everyday practice and build it. So in your practice in Florida, are you also, because I obviously have a lot of myofunctional therapists that follow me, so are you utilizing myo in any of your protocols, or how is therapy playing a part? And because trust me, I know therapy can also be a little tricky too.
Mm-hmm. It's become almost routine. You almost don't find the patient who won't benefit, or at least who you won't mention that, as an intervention. In fact, when you talk to patients about whether it's, CPAP or appliance positional therapy, so whether you want to call it non-surgical or medical, non-invasive, whatever you want to call that group of treatment, myofunctional therapy has to be actually in that mix, right? Because it is universal. It is very little harm done, right? I mean, it fits the criteria as all of that. That for kids is super important, for adults as well. I mean, just this morning, the classic story, right? The 11-year-old kid's getting expansion, seeing the myo sees the kid, sees the dad looks the same. They toss him over, but hey, yeah, the guy is 50 some years old, expanding that guy is not the same thing as expanding that kid. Okay. And neither is doing myofunctional therapy, although poor guy still has a great, like a grade 4 tongue tie. So, and he's 50 something, right? So it's like, oh, but yeah. So the answer is I've always, as soon as by the way, I did not learn about myofunctional therapy until, of course, CG supported the second AAMS meeting in Chicago. I think this was back in 2015. And very quickly, though, I realized that it's not even about the post-treatment, post-surgical myo. It's really about the pre. It's not the rehab, it's the prehab. And it also fundamentally changed how I see the airway. Well, actually, I'm extending this because you just asked if I work with myo. The answer is almost every case.
Always, yes.
But one of the main reasons I really have to stress this is because when I throw out a random question, and I say, to random audiences and I say, hey, what's the airway? They think it's a trick question, but I'm just like, no, really, what's the airway? And you'd be surprised. And you can try that. Next time you go to any academic or even with colleagues, if you ask them, what is the airway? I don't know. You get all kinds of answers, but.
What kind of answers do you get?
No, they just give me this confused look like,
yeah, the
airway's airway. I'm like, yeah, what is it? No, it's airway. And a lot of them think about that black stripe on the CT, on the cone beam CT, right? They think about the hole, right? They think about this dark hole, okay? And it's narrow or it's big, right? Okay, well, what makes that hole?
Yeah.
Right? Well, it's muscle. The airway is muscle. And the minute you understand that, you understand almost everything else that we do and why it works or why it doesn't work. You can explain all surgery and the good outcomes and the bad outcomes by explaining muscle. You're not going to get it explaining the size of the jaw. You're not going to get it explaining, you have a large reconstructed airway on the cone beam CT scan or not. You're not going to get it from an AHI. You're going to get it if you think about the upper airway, what it exactly is. It's a bunch of muscles. Okay, if you get that, then everything else makes sense. I can make the entire rubric of sleep apnea treatment make sense by talking about muscles. But that's what it is. We've changed entire, there was a company doing, ultrasound research for the longest time on the airway. It didn't get anywhere. And I said, guys, we're talking about muscle here. You guys keep scanning this black stripe of a hole. You aren't going to get anything out of that.
And muscle has memory.
But look at the muscle, and you're going to get something out of it. We published that in the highest ranking journal in JAMA Otolaryngology. The minute we pivoted, we asked them to use that ultrasound and look at the muscles. Not the black stripe and not, the black stripe shrinks when they, no. look at the muscles and look at the quality of the muscles. And that changed everything. So I'm just saying that since airway is muscle, you kind of have to reckon with your myofunctional therapist at all stages.
Well, I really appreciate you saying that and clarifying it. And I don't think I've had anyone explain it so eloquently because, I was drawn to myofunctional therapy. Like I said, I felt very like I had a central nervous system response the first time I was in it. And I've been doing myofunctional therapy for a long time, but when I really started to do myofunctional, like live what I was preaching and work on myself, I had a very large transformation. I mean, even mentally, Zarush can talk about it. And I became very public about what I was going through and how I was on Lexapro and Adderall and all these things. And 5 years ago, I really openly admitted that all of those pills I was on was because I was just band-aiding these other bigger issues I had, and my muscular response, the way my airway responded, the way my sleep was just this hamster wheel of continuation of back and forth. And I really had to address my imbalance and all of these other things I had going on that all started when I was just little, little Melissa. And my mom didn't know what she didn't know. And, they were all just trying. And I hear you speak about that. And when I heard you talk about the central nervous system and how that, like a little bit of how those things are all connected. I mean, I've never met somebody who doesn't sleep that is a completely regulated human. I don't mean that to be rude. You show me somebody who's got a lot of anxiety, a lot of depression, a lot of those big feelings. There's usually sleep issues wrapped up into that. They kind of come hand in hand. And I have found with myofunctional therapy, it's a great entry, a great gateway drug, if you want to call it, to be able to help providers like yourself and other great providers to, create this relationship to help patients see more than just a structural response.
I like how you coined that as a kind of a gateway drug, because unfortunately today we really do have gateway drugs for sleep apnea. You have a pill that's essentially an anticholinergic and an antidepressant, right? That pill. You also have the GLP-1s as if obesity is the only cause of this, but they have become the true entry pills. It worries me a little bit because the bar of writing a script for it is very low. Yes. And a lot of people be taking it and probably delay some treatment until they just, start to be able to get into the root cause. But more so than ever, myo needs then to be pitched exactly like that. Well, listen, if you're willing to take a pill, okay, are you willing to also do some exercises to help yourself?
Well, that was, here's the thing, Dr. Stanley. I had a baby. I call him my bonus baby. He was I have an older 15-year-old and a little guy 8. Yeah. And I was older. I was in my later 30s and I gained a lot of weight after that baby. Okay. And I had all these other sleep issues and grinding and clenching, all this stuff. I was heavy and I was, physically tired, all of those aspects. And I knew all the things I was supposed to do. And yes, I could go on a GPL-1 or I could do all those things, but I had to move my body. I had to do both, right? I had to hit it on both sides to be able to treat it. And I tell everybody that I went through those years because I'm one of those learners. I've always had to learn the hard way. I've had to live it to do it. And me and Sarah Horn, we own a company called Faceology. And 2 years ago, we made a decision. We treat all ages, but we don't treat the children anymore. We do not accept a child to do myo unless the parent does the full therapy with the child. And we have gotten amazing. We don't charge for the parent. We don't do anything. We give them extra kits. We give them tools. It's all great. It has been a game changer.
I believe it. I've had fathers and sons do their frenectomies and expanders at the same time. The kid's going to beat the dad, every single time. Absolutely. But I'm like, it's family bonding, that time of the night, you got to do your expander.
The conversations these families, first of all, the blaming mom or blaming dad, genetics, all these funny things. But we've had where we had this one parent, husband and son, he said, he came back, it was kind of emotional release in a sense. He said, I just thought I had anger issues. I didn't realize I didn't know how to breathe. And I thought my kid was doing the same thing. And he goes, and then we weren't sleeping. And, for me, it just is this beautiful reminder how we're all connected and how the body is this system, not just teeth, not just a nose, not just ears. Because I used to make a joke. I could run and sell a lot of treatment, dental treatment. And I used to make a joke. I go, it sure would be easier if the parents would just drop the teeth off and come back and pick them up. We'd fix them up. I go, but they always stay with the teeth. And then I got to deal with the, with the patient. And working on those behaviors is, a big component of us helping to move this needle. And, if I hear one more person tell me to show me the research, I'm like, okay.
And yes, and you can. There's plenty of research to show in every direction. But the point is, it's just how it's interpreted, right? Every project has its strengths or weaknesses. Yeah, but we have to deal with that conversation. Sadly, though, I do this silly exercise every talk I give, really. I throw up 4 simple things, and I got that starting from when I was teaching. So Sleep and Dreams was this undergraduate course, the first course ever on sleep. That Bill Dement started at Stanford about 40 years ago. So I took that as an undergrad and went back to teach as faculty. But, I throw up simple things. I throw up a comparison of sleep endoscopy. One's like totally collapsing, one's totally open. I ask them whom they would rather sleep with. Everybody picks the open one, however they interpret that question. I show them a narrow jaw and a wide jaw. I ask them, whom would you rather kiss? Everybody picks the wide one. I show them a guy of mine before and after MMA. I just ask them, which guy looks more awake to you? And they always pick the post MMA. And then I show them 2 people sleeping in the MRI. So, one with sleep apnea, one without, in their 50s, and I ask them to pick which one, and everybody picks the correct one. I mean, fundamentally, I'm not saying sleep, breathing, and the stuff we do is not complicated, it's super complicated. But there are some things that are so universally, what's the word? I mean, it's just so, it's kind of like, whether you're trained or not, even if you just ask a random person, look at the shape of this thing, and they all pick the one that seems to work better.
Because our eyes, like feng shui or balance or symmetry, as humans, aren't we just naturally attracted to things that have balance, good curvature? I don't know. I always, because of the way I learn and because of my sleep issues, I always was a very visual learner. I struggled with certain things, but so analogies have always helped me. And I remember thinking to myself, I could never go take my car and just get 1 tire. They always made me get always had to get 2 because the car needed to be balanced. And if your suspension was off, I had an uncle that was a mechanic in basic engineering. And I thought, but you'll let a 4-year-old or a 3-year-old stay in crossbite. You'll let their entire body work like 2 tires that aren't balanced, and you'll let them create muscular relationship and memories and habits, and then say they're going to grow out of it. I remember my uncle told me, if you keep driving the car like that, you will ruin the chassis and the suspension, and the car will never drive the same.
That's actually a really good analogy, especially if you're talking about the 2 tires and, you've got that crossbite and the mandible has to pick one side to be, and you've began the process of messing up your joints.
Yeah. And then you wonder why one eye is higher than the other, or the cheeks. When I look at TMD patients, a female, I can tell you how she does her makeup because she's going to contour more because of how much more. I don't even need to look in your mouth. I can see the way you set up your makeup. For MMA, to me, it's like just come out of the mouth, look at the face, watch the body, and most of it will tell us a story, right?
Because it is form and function. And so there are basic things, especially with the head and neck too, It's not an aesthetic even. I know sometimes people say, well, is that an aesthetic approach or whatever? But what it is really, especially with the head and neck, what looks good usually functions well. I mean, it's kind of overly simplistic, I know, but it's kind of true, okay? I mean, because functionally, it has to be in the right place.
Dr. Boyd. Dr. Kevin Boyd, or we go back into you talk about how species are attracted to each other because of procreation, or one looks healthier or something along those lines.
Yes.
This isn't me choosing what one looks like; it's just how we evolve. Yeah. And when you see somebody who's really struggling, on the struggle bus of I was that person. I tell everybody, you look at me, people are like, oh, you look great now. I'm more balanced. I breathe a little bit better. I'm still from New Jersey, so I talk too fast and I get hot. I lived for 40 years in really overdrive parasympathetic. And so I got defensive and I would try to protect myself. I didn't fall asleep at night, Dr. Stanley, because I thought there was something fundamentally wrong with me. And then finally, when when Zaghi took a CBCT of me, he looks at me, he goes, this is what he said to me. He goes, God, he goes, you're so brilliant. He goes, but you're a little all over the place. I said, I know I have great ideas and I see something. I don't always know how to articulate it. He goes, let's get you in, takes a scan of me. And he goes, Melissa, he goes, you're like, you're kind of out of a cocktail straw, you're really back there. I was grinding on everything, clenching. And he goes, you're trying to protect yourself, and I, again, emotional release. I said, I feel like I'm always having to protect myself. And I have taken that into every patient, every client I've worked with, and I've learned and I've worked through it. And that's like where the passion drives of like, I just never want anyone to feel like they're crazy or that they're alone, right? And I feel like this work and the things that you guys do and the research of putting yourselves out there has opened the conversation for us to have, that all of this is connected. It's so much bigger. And I always think like everything should be wide, which, if you're okay if I shift for a second, because I could talk to you for hours, is I'm a hygienist, but I started in ortho. And so I have this little story. I worked with this guy in New Jersey. His name's Joe Arve. I like to give him credit. He's way retired now. He was an engineer, maybe a biochemical. He was a different engineer before he went to ortho school. And Dr. Arve had a swag about him, like he walked into a room and Dr. Stanley, you could see an Arve smile in the mall, right? Like I remember we went out to a Christmas party and he goes, that kid's my kid. Like it was big and broad. He used, so this was early 90s, early 2000s. When I was assisting him before hygiene school, he used all removable appliances, CD dialyzers, Maras, everything was big. Everybody got expanded and broad. I don't think he was ever doing it for the airway. He wanted big, beautiful, bold, bright faces because moms came in and said, I want they saw that kid look one way. They wanted their kids to look that way. He also was able to raise the bar. Moms didn't come in. If you lost your appliances, he just looked at you, walked away. Like there was like a bar that was leveled. And that was how I learned about ortho. I only knew removable. I didn't even know all this cemented because of how he taught me. I think that gave me a little bit of an advantage. And now I look at expansion and I'm like, what you guys are doing with, I think MARPE 3D printing, it's changing the game. I'm so excited of where we see rapid expand, palate expand, all those things. I'd love to talk to you about dome and like all these concepts, because to me, this is the needle that's moving a lot of things that I think a lot of people don't even know about or even know what to look for. If you'd be open to chat about that.
Yes, I would. And in fact, understanding the maxilla, I think, is more important than ever. I will say, so how did this all start, right? 2013, I started. Now, I finished a fellowship. I started my faculty position in 2014. And one of the very first meetings I've had with Audrey and CG was because CG says that you need to start expanding adults. And I can tell you that I had no idea why. But that's okay. He says so. Okay. And I remember I went to clinic and I left him and Audrey there, and CJ was drawing on his tissue paper, these dots, and screws. And I think he had seen Juan Moon's work already. Okay. And also some people in Europe. And so he really wanted us to do it. Okay. Well, here's the kicker. So we say, okay, we'll start doing it. But these are patients coming in with normal occlusion, whatever normal means, maybe the teeth match. But now you're telling them you need to expand them. I mean, how are you going to do that? I mean, like it doesn't make sense. And so for about a year, literally the way after I scope them, take pictures and show them, I would say that, okay, so you have this high arch palate. And, because of that, the nose is narrow and then the tongue doesn't fit. And we prefer this more of a dome-shaped palate. Okay. So in order to achieve the dome-shaped palate, then XYZ. So that's how that dome terminology came. And it didn't even come as a medical term. It literally was describing what the heck we were doing for the patient. So by the time when it came for us to publish it, I also was careful to call it something that was technique insensitive, meaning we did publish the way we did it, but the name of which, distraction osteogenesis maxillary expansion, all we're saying is we're growing bone. We're not bending teeth, moving teeth. We're growing bone when we expand the maxilla, okay? So what's interesting is, today you have MARPE, MAPE, SMARPE, MISMARPE, SARPE, MIND, ease. You can keep going. Bachata. Actually, that's not a real treatment. It's just a dance I like. Everything talks about a technique and is committed. How committed? Well, MARPE now, people talk about the slow MARPE, but you baked rapid in there. It's MARPE is mini implant assisted rapid palate expansion. And now they say we do slow MARPE. What the hell? How much are you going to confuse your patients? Right? And so to this day, dome remains the destination. We are growing dome-shaped palates. Now, whether that comes from, early breastfeeding, whether that comes from early myofunctional therapy, whether that comes from pediatric expansion, whether that comes from adult expansion, don't care. Bottom line is we're trying to establish something so that the patient has a fighting chance to breathe well through the nose and have pharyngeal wall stability during sleep. And trust me, patients understand what a dome-shaped palate is. So to this point now, today, with a team of folks, they decided to call it a Dome Zero, and that's fine. Yeah. With no diastema, skeletal expansion with clear aligner at the same time, and it is very slow and it's very good. And we had to learn all of that. I could tell you we tried like all these different surgical cuts. We tried all these different expanders and devices. We lived through the Wamoon expanders. Then we got to the custom-made expanders, and now to the truly only skeletal, no diastema expansion, no surgery, almost always. The field changed this much in 10 years.
Crazy.
But the destination never changes. You can keep calling your technique whatever. No one's going to remember it in 10 years. But the destination will always be remembered.
The conversation of lower expansion. How do we answer that? How do we address it? Where are you at with it? What do you talk about it?
Yeah, so remember that everything's on the continuum, right? So that's also what we have to remember. If we understand the condition that we're trying to treat rests on the continuum, everything's on the continuum, well, so is expansion. Okay, so limitations, right? Sure. If your lower teeth aren't lingually inclined and, they're straight up like this, well, it's just going to cost a heck of a lot to expand the upper, because on the lower now, on a lesser degree, you could do, SFOT and bone grafting. And on the bigger scale, you need to do a midline split and distract the mandible, right? Now in kids, easy, and adults, kind of much more involved. Yeah. It comes down to the patient and what they need, right? If they, happen to have that very favorable anatomy of everything's tucked in, and so you just upright the lowers and you buy yourself a good bit of expansion, you're great. If not, it's a discussion with the patient, and, now you're just weighing risk and benefit. And, if it takes that much to get 4 millimeters, do we want it?
Yeah. Well, one thing I've always been curious, and maybe it's a silly question, but I think there's people that wonder it. I did early on in my career, I played around with some of those, a lot of the prefabricated appliances and stuff. And I'm a big fan of all tools can be utilized if the particular provider knows why and how they're using them. The one thing I found, I spent a lot of time with MyoBrace. Chris Farrell was actually, that was actually my first consulting job ever, was to help offices who bought MyoBrace systems that were failing. So I ended up in Denver, and I was in this practice. And the one common thing I found, she had a lot of cases, was The one positive about those prefabricated bite was that it opened the bite. Like that it brought the vertical of the bite opened enough that there was a period of time that we saw a change in the autonomy. The child would be a little bit more comfortable, or it put it in like a pseudo class 1 that then we actually got to see how the muscles would act if they were in the proper bite. Now, the problem is people would leave them there too long and then it would create, some more issues. So it was like not knowing when it was time to get out of the relationship. So when I think of people not doing anything with lower expansion, I'm like, there's such a benefit by opening the vertical, like, giving that stability to bites. Am I wrong for thinking like that? I don't know. I feel like I saw that.
No, not at all. And I think this is where the fields can come back to. It's funny, right? So look, in the last 10 years, if you go to any of these dental meetings, be it the Spears or the Legacies or, the orthopreneurs, you have orthodontists will show the pre and post expansion, right? And they only show the upper jaw. Okay. And it's really funny because I'm like, wait a minute. Okay. So do we just forget there's another jaw, right? Did we forget there's a mandible? And I'm pretty sure we have to reckon with it because the lack of understanding where to start with the mandible, I think runs us into the problem of, okay, now you've expanded the maxilla, bite's still not quite right. And now you really have TM joint issues. And now what? Okay.
Yeah.
But see, here's the thing. If you now date yourself back 30 years ago and you're a dentist was more than teeth, what did you do? You did oral facial pain, you did TMJ. And when you talk to the TMJ people, they only look at the mandible. They never look at the maxilla. Okay. I have a awesome oral facial pain expert here, Dr. Menschel, 30 plus years experience. He is awesome. Every time he sends me a patient that he thinks can't breathe, can't sleep, they all look the same. They are all super narrow. And then I would ask him, I'm like, Dr. Menschel, this is narrow. And all your patients look the same. Whether you send them to me, whether they're 7 or 60, they all look the same. And I asked him, do you guys look at the maxilla? And he says, no. For them, it's the pano, it's the condyles, it's the mandible. Maxilla, irrelevant. Okay. So we've gone through that era. And then now we've gone to the maxilla only and no mandible era. And I am certain in the next decade is about putting this together. Now, there's several things here.
Yeah.
Anything from deprogramming the mandible, anything from really knowing where you're starting. Because look, if you have a narrow maxilla, it's got a cant, it's got asymmetry, that joint is asymmetric too. And so it's beyond just your capability of matching the expansion. Can you establish a comfortable, reproducible bite for the patient when you're done? Or if they need more surgery afterwards, what are you going to do? So fortunately, now that we're tired of looking just at the maxilla, since we've seen enough of it, we're going to bring the other jaw back because you have to. And besides the fact that it honestly is extremely difficult, almost next to impossible, according to most, to change the occlusal plane, to change, to really create counterclockwise rotation for the lower jaw to pull forward and benefit the airway. We have lots to figure out with the mandible.
This is not my wheelhouse. I know muscles. I know facial symmetries. I know how human bodies behave, and I know the people attached to them. Obviously, the structural, you leave to the structuralists. But sometimes I'll be honest with you, Dr. Stanley, I said to somebody, I'm living right now in Lafayette, Louisiana. And I say, God brought me here for lots of reasons, but it's interesting. I end up in some conversations that a lot of times I don't want to, because like I'll have people, have structural arguments, and I'll say, listen, I sometimes feel like it's a Jewish person and a Christian person having an argument about Jesus. And I'm not sure we're going to get to where we need to get to right now, because it's a bigger, conversation right in this moment. But one thing I said to them is I said, muscles, if I'm correct, Anatomy 101, muscles will win over bone most of the time. And you show me, one thing we've been doing a lot in the teaching of myo now is the last 2 years, I've been working a lot on facial mapping, right? On talking about how much the cognitive load will show in the eyebrows, in the voice tone, and how much the jawline, and breaking the face up into thirds.
Yeah.
And how this mid third will stay very frozen. You'll get some nostril flaring, but then these kiddos and adults that have really had mandible strain and crowding and really, they have a lower lingual holding arch. They have all this stuff. What will happen is you'll get these it's like the mid face is just frozen in time. The upper lip is not moving very well. I'll make a joke that the poor mandible is just wearing so much, wear and tear. And then the eyebrows and the eyes are like overly working. And we're creating all of this inflammation and imbalance. And then later on you see, and I was showing these cases and they looked at me and they said, but I mean, the teeth are fine. And I said, yeah, but the muscles, and I just, into these little feeling things. So I'm excited to hear you say this next part of bringing it together, because I think we've been spending so much time playing with the muscles and looking at the system. It is an exciting time to have bigger conversations of how we're going to implement this and bring this into a true protocol to help people, because that's
right, because you can selectively work on those muscles too, right? You can selectively weaken some with Botox. You can strengthen the other one. But you also have to remember that muscles, of course, work in opposing pairs. So even in the cosmetic world, for example, the movement is to do less Botox, and that you don't need to do it on both opposing pairs of muscles. You just do it to one of them, and the other one won't move as much either. Right? And it's so interesting you mentioned that. But look, at the end of the day, right, the facial muscles and our airway muscles are attached to the same bones. Okay. So I like this mapping idea. I hadn't thought of it as much until recently, where I kind of want to teach cosmetics a little bit differently, because I feel like, I'm just using this is like a little pet project, but I'm just trying to, because for me, it's all about integration, right? If you integrate these pieces. So long story short, I feel like if I taught a course with a Botox person, injector, and I teach it with a myofunctional therapist who talk about facial reanimation.
I'd love to show you what we've been doing.
Yeah. So then you put the three together, you actually have a real course, because you've got where the bone is, where the layers of the thing is. You've got chemo denervation, and then you also have animation from the muscles. That would be how at least I would go and pitch a cosmetics course today. Not different than airway. It's the same thing, right? It's really the same thing. But I haven't quite seen it put together like that yet. But for the patient, it's very favorable, because what you're talking about is as much non-invasive, but very motivated, dynamic ways to address this, and more likely to be of long-term, efficacy.
Yeah, I just go back to that little story I shared you about that orthodontist that, whatever he was doing that became his business card, just to kind of come full circle, because I could talk to you for hours, but whether it's implementation or business, the one thing providers running a business is having a niche, having a legacy, being able to have a signature, something, because that attracts the consumer, attracts people to you. And the more we make people look good, feel good, they go around and they tell the world that. And then that becomes your business development plan. That becomes your niche. Yeah. And now you're busier than you know what to do with, right? And you have team members that are telling their families about it, and you got a wait list, and you become that destination practice. I mean, that's just been my mission. Is I just want, I feel like to give my way back to the airway movement is to support and build the best badass practices and teams, so that doctors can do and feel supported and be able to deliver this to people. But it does take meeting people where they're at instead of dragging them to what we need, right? Is that something right?
Absolutely.
Because in the beginning, I felt like we had to prove why we were doing what, right? It felt like a little, so I'd love to kind of, as we come full circle, just chat on that, how you see the future approach. And, if you had your dream vision of 10 years, if I sat with you for your business plan, what do you see? What do you imagining and hoping for?
Yeah. My core value all this time has still, when it comes to innovation in our space, it really comes from integration, meaning we don't need to invent many more things. We have plenty of tools. It's about how we integrate them so they work in this model. So I will say this, for example, I chair a surgery course in Singapore, and it's a sleep course. But this year, I deliberately brought facial cosmetics with sleep. Now, why? Well, I'll give you an example. We will have 5 or 6 rhinoplasty surgeons talking about noses. We will have 5 or 6 jaw surgeons talking about jaws. I want them in the same room. Come on, guys. The guys who do noses don't do jaws. So clearly, sometimes the jaw problem, it's not the nose is too small or sunken, it's the maxilla that's sunken, okay? And you can create a big nose that doesn't breathe, or we can work together. At the same time, jaw surgeons are trained, but not in nasal surgery. Okay. But look, when we talk about our patients, right, I hope we can agree. We either breathe through the nose or the mouth. You can argue what's better. We're not going to get into that one. I'm strongly on the nasal side. The bottom line is, but they're connected and you can't separate them. Okay. And usually when you go to meetings, you have to go to 2 different meetings. You have to go to a facial plastics meeting to learn rhinoplasty, and then find some kind of a jaw surgery meeting to learn jaw surgery. No, it can't be like that. So I am starting that process of bringing both groups of surgeons together, and at least they can go to one meeting, and I want them to sit down and look at the best of what each other is doing and figure out ways where when the patient needs both, how are we going to collaborate and make this happen? In the same meeting, I have cosmetic dentists. I want them to be there. The smile design is important, but don't do your smile design by making a bunch of big teeth. Do your smile design and recognize that it's a narrow jaw that we can absolutely address functionally. And that goes back to your orthodontist, or actually to countries like Brazil. They love these giant smiles. There is a reason why they're very good with expansion. They have great myofunctional therapists, but they were always doing it for the aesthetic purpose, just accidentally that happened to be good for the airway as well.
Yeah.
So we'll have a section on outpatient procedures where, we'll see the best of Botox, but we'll also see the best of laser snoroplasty. Bottom line is, I know none of this is connected today, but it has to. There's no reason to go into a clinic to get Botox done, and then you can't get your a little snoroplasty if needed, and also to be given the right information to get more care if needed. Right? That's how the cosmetic industry was built, because, it was like do nothing and then get a facelift. Well, no one's going to deal with that. So that's why you have fillers and Botox and laser and RF and all of that to bridge that gap.
You got to meet them a little bit.
Sleep will have it, but we need to learn from our cosmetics colleagues about it. And our cosmetics colleagues have a lot to learn about airway and function. Well, so anyways, that's where I see is it would be very boring just to do it ourselves. And we are a big enough group now to now go to them and say, guys, we got to collaborate. Bite, breathing, and beauty. It's not just, whatever, looks maxing. It should be wellness maxing.
Yeah.
Okay.
Yes. And it should be
we
easier.
Can absolutely do it. This is the time. So I think that's where that integration comes in the next decade.
Well, I thank you for that, because, and to just leave it. I mean, I know you've worked close with a lot of, my therapists, but like even my own case right now, I have access to a lot of great providers. I would have to go fly to one. I got to get my expansion done by one, but I also have all this wear and tear. And I had my root canals removed because they were messing things up, and implant issues. I have to fly to 9 different places, plus run a business and take care of my kids, so that I can get this ideal case. And that's a lot for someone to to do. So to hear you say that and to bring a little excitement that that's possibility, because I do care about the cosmetic. I want to smile beautiful, and I want my teeth to look bright, because I want to look healthy, and I want to look.
And it makes sense. That's why the Dome Zero movement really took off quickly, because you're just expanding the jaw, wearing clear aligner at the same time, no diastema, and you just move along with life. And then also, by the way, with that slow process, it really allows the myo to do its work along the way. You're not having this giant sudden change and having the body trying to reconnect, very suddenly. But I mean, what originally drove it, of course, was for the aesthetic purpose of avoiding that diastema. And also when you close, then you have that black triangle gap and all that. So I think it's just overall wellness. Okay. And by breathing and beauty, why pull one apart? Like why, when you can try to get all pieces done, why pry it apart? Like, okay, I'm going to do the airway, but I don't care if I look bad for it. No, you do care. Okay. And let's just put our minds together. I'm not saying I have all the answers, although I'm developing a lot of good ones. And then as I bring the colleagues in, I think it'll work. And we have now just doubled our people who support us, because if we get all the cosmetic people realize, I can also help with the function, we have actually just doubled the workforce of people who can take care of our patients.
Yes, which
right?
That's all we want to do, right? That's why everybody took the oath, was to help people.
Yeah.
I'm so excited to just hear like the things that you're up to. And so for people that are listening, if they wanted to, come see you in practice or take one of your courses, or I'd love to refer a bunch of people for any of your consulting or support, like what's the best place to find you? Like where do they go?
Thank you. Well, it's been, transform myself out of the ivory tower to try to make a lot of this information more digestible. So I have a very simple website that I maintain myself. It's just drstanleyliu.com. And you can connect with me through there. I have put a lot of the papers, a lot of these landmark papers on the website. That's very accessible. And it also includes the meetings that we'll be teaching. And yes, I really would, if anything that we talked about in this podcast, is of interest. And really, right, the goal is integration for innovation. We have a myofunctional therapist coming from, unfortunately, Singapore meeting is an academic meeting. It doesn't pay. So it's real hard to get folks out there. I'm amazed that folks are willing to go, but we have myo represented in the meeting. Now, the hope is it blows up so that this whole aesthetic, functional, airway, like this is not three separate groups. We need to be in the same room.
We do.
And then it will work really well. And I think in the end, airway wins anyway, because they will like it, right? Because they're kind of probably bored, whatever, right? Seeing the airway for them would be like, oh, that, and then that's why I say, like, we'll pull them in to help us and help our patients. Yeah. It'll work. I'm sure it'll work.
It will absolutely work. What we've seen happen in 10 years, as long as we keep having conversations, opening doors, connecting dots, and just making people, feel seen and helping them out, I've only seen it get better and better. So I thank
you for connecting the dots, because that's what you're doing. You bring all of us here. We get a chance to, to pitch our thoughts, and where everybody is, and you connect all of us. And so I'm very grateful.
Well, I can't thank you enough. We have one little thing, the way we end the podcast always is I ask each guest, as I ask them, when they think of the word or the title, Mind Your Mouth, what is it? What brings up to you? What do you think about, or what is the connection to?
Well, for me, and that's just because it's personal problem. Yeah. For me, it would be more so along the lines of, be careful what I say. We want to be as accurate, truthful as possible, and communicate directly. So for me, it would be more like, and you know what, that makes sense too. There is a lot of things I want to share, but most of the times I don't talk about something unless at least I've published it. Doesn't mean it's right or true. At least it's been peer reviewed. I don't come up with concepts that, like in my imagination, I don't do that. And so it is important to mind what I say. Anyway, that was my first. That's because it's a personal problem. Okay.
No. Do just to be quick, the reason we started asking that was because I believe it's so connected and so personal, the mind and the mouth. And we have found, it took me a long time to launch this, and it all came back to is I just really loved having the ability to have great conversations with great minds. And without their ability to use their mouth, they wouldn't be able to articulate it. And whatever that matter, whatever it means. So it's become a really fun thing. Everybody has
it's easy to remember. I will tell you that, but yes, to everybody, if you're asking the first reaction, mine was, oh yes, be careful.
And what? I should mind, to be honest with you, there's been many times I should mind my mouth. Yeah. Well, thank you so much for your time.
Thanks for having me. Thank you.
Again. For everybody, this is another episode of Mind Your Mouth. Till next time, everybody have a great day.